Sorry, I have muted mic. Can you hear me now?
Yes, Professor.
Yes.
Thank you very much. Okay, so today's subject will be lymphatics and related disease, and I'm Seok from Seoul National University Hospital. And before starting the lecture, I would like to inform some. We are actually planning the next semester's lecture and content with Professor Dong-Soo Lee. So, and on behalf of Professor Dong-Soo Lee, I would like to ask every participant today that what kind of like contents or subjects that might be preferable or want to hear. And then regarding the subjects and contents, we will choose who can be the best candidate lecturer for the next semester. So for the, we will put a link in the chat. So you can find out a link in the chat, and then please fill out the form. And at the last, for the free comments, if you can freely tell us what kind of contents you want to hear from us, we will refer to that and plan for the next semester's lecture series. So thank you very much, and I would like to welcome all for the participation. Okay, thank you, and now I will start my lecture. So actually, today's lecture contains two parts. First will be about lymphatics and related disease. So actually, the most common disease that we know and we are familiar of the lymphatic disease is actually lymphedema, which is like due to like primary or secondary causes. However, recently there has been a hype of interest of other diseases which are related with dysfunction of lymphatics. And so I would like to introduce some diseases that are related to lymphatic dysfunction, not only lymphedema. And the next content will be so more familiar to us, the lymphoscintigraphy and lymphedema. Okay, so I will start for the first session about lymphatic and related disease. So from starting, lymphatic system is actually a vascular system which returns the fluid to heart. And it helps large molecules enter the blood like hormones or lipids. And it has a function of immune surveillance. And so the high pressure in the artery causes the interstitial fluid to come out, and most of it enters the vein again. But due to the limited capacity, there is a remaining interstitial fluid. Then the pressure in the interstitial space will rise. And then this leftover fluid will go into the lymphatic vessels. So the fluids that are these excessive fluids that are collected through the lymphatic is called the lymph. And these lymphatic vessels contains a valve. So there is, in the lymphatic vasculature, there is only a unilateral directional flow is possible. And this flow is actually created with the help of arterial and muscle contraction. And if you look closely, this lymphatic capillary contains also the lymphatic endothelial cells. And these lymphatic endothelial cells have button junction, which has sphere structure so that these spaces So these macromolecules, even cells and immune cells, like can go through. And when it comes up from the capillary to the collective lymphatic endothelial cells, it changes to a zipper type junctions, which has a relatively intact surface. So the just briefly, like this capillary has a collective function, and then it moves on. So these collective LECs can actually are more intact in their shape, and it has a function to move the lymph to our systemic circulation. And after the drainage through the trunks and ducts, again meet the systemic circulation via like jugular and subclavian veins. And in between the process, lymph also pass through the lymph nodes where it can have their function as a immune surveillance. So before introducing some studies that have focused on the relationship between the disease and lymphatic dysfunction, we need to briefly understand about what are some important molecular markers that are relevant to this lymphatic functions or lymphatic disease. So these markers in the tables are markers that will be encountered frequently and markers that are important for lymphatic evaluations. So PROX1 is a transcription factor necessary for the maintenance of lymphatic identity and are mainly involved in early developmental period. And the VEGFR3 is an essential lymphatic receptor tyrosine kinase with VEGF-C. And with this VEGF-C and VEGF-C receptor 3, it can go on for lymphangiogenesis. So later on, you will see some studies that use this VEGF-C for improving the lymphatic function or improving the lymphangiogenesis. And so because these markers have their important function for lymphangiogenesis or making lymphatic vasculature, when there are defects in this related genes, it may express as a disease, which is accompanied by the lymphedema. And you can see in the table, like if there is a mutation in the VEGFR3, it will come out as the non-miliary disease. And like if there is a defect in the FOXC2, it will show as lymphedema dysgenesis syndrome. So as previously mentioned, the most widely known malfunctional state of lymphatic is lymphedema due to obstruction, which will be discussed in the second part. And without such abrupt obstruction, lymphatic function still can decrease. So in this study actually showed that included the melanoma patient who underwent the sentinel lymph node biopsy with the lymphoscintigraphy. Actually, they used the technetium sulfur colloid, and the count of the sentinel lymph node was measured and what they found was that the uptake count decreased according to the age, which actually shows that there is a lymphatic function decline with the age. So furthermore, if there is such a dysfunction in the lymphatic, it may induce or have relationship with the disease status. And these are some summaries of right now known diseases that are related with the lymphatic dysfunction. So firstly, is the cardiac lymphatic. I would like to introduce about the cardiac diseases. So firstly, cardiac lymphatics covers all layers of the heart and drain the lymphs to the mediastinal lymph nodes. And the transport of lymph toward the mediastinal lymph nodes is linked to cardiac contractility and heart rate. So from the previous studies, it is known that myocardial infarction actually induce cardiac oedema. And these oedema can cause microvascular and cardiomyocyte dysfunction and damage, which is detrimental. So there is a need to reduce the oedema, and it may relieve the injury induced by the myocardial infarction. And the physiology that can actually reduce this oedema in the cardiac is known to be the cardiac lymphatics. So this study actually reported that in the VEGFR3 mutation mice, which the VEGFR3 signaling is downregulated, showed a significant structural change of lymphatic vessels. And consequently, because there is a lessened function to clear out this oedema after the myocardial infarction, that this myocardial infarction actually lead to higher mortality in these mouse models. So, and also MI, this myocardial infarction can induce not only oedema, but also inflammation after injury. And as so, this study showed that stimulation of cardiac lymphatics by VEGF-C can increase the clearance of the cells to the mediastinal lymph nodes like this, and then it can consequently lower the risk of the myocardial infarction related mortality. And also the recent studies have found out that adventitial lymphatic capillaries increase during atherosclerosis, and they may have a preventive role. So dysfunction induced by this lymph node dissection can worsen the atherosclerosis. And they found out that the T cell accumulated in the plaque, and it may have, so these lymphatics in the adventitia may have an important role in the pathophysiology of atherosclerosis. So this was about the cardiac disease, which are related with which can be related with the lymphatic dysfunction. And secondly, I would like to introduce about Schlemm's canal. This Schlemm's canal is actually a lymphatic-like vessel in the eye that is actually critical for the drainage of aqueous humor. And this, from the studies, it have shown that these Schlemm's canals have similar structural markers which are related to the lymphatic vessels. So as you can imagine, if there is a dysfunction in the Schlemm's canal, there will be an increase in the aqueous humor, and consequently there will be an intraocular pressure increase. So it will result as a glaucoma. So glaucoma is as you will know, is a disease which are accompanied by increased intraocular pressure. So this Schlemm's canal dysfunction is the significant pathophysiology related with the glaucoma. So therefore, there has been a study to find out strategies to enhance the Schlemm canal function. And they thought that by enhancing the Schlemm canal function, it can have potential to relieve glaucoma symptoms. And this work reported that 2017 revealed that angiopoietin type 2 signaling is essential for Schlemm canal function. And as previously mentioned, impairment in this Schlemm canal function induced glaucoma. Not in the slide, but interestingly, increased type 2 activity with an agonist antibody actually restored the Schlemm canal function. And after that, consequently, it reduced the glaucoma phenotype. So these like type 2 or angiopoietin type 2 can be a further such a target as a therapeutic strategy for reducing the intraocular pressure. And further, it could be a target to treat the glaucoma. So there is a ongoing studies regarding it. The next lymphatic structure that I would like to introduce is Lacteal. This Lacteal is a lymphatic capillary that absorbs dietary fats in the villi of the small intestine. And as seen previously, Lacteal, as it is a lymphatic capillary, also have button and zipper type-like junction, which can be controlled by the VEGF-A in this here for the Lacteal. So since this chylomicron like lipid, like just macromolecules may not pass through the zipper junctions, so the modulating the Lacteal junction can alter the absorption of dietary fat. So what has done in this study is that as when they deplete the FLT1 and NRP1, this induced a Lacteal zippering by activating the VEGFR2. And because this there is a induction of Lacteal junction zippering, the macromolecules cannot easily pass through this lymphatic capillary. So there is a reduced uptake in the chylomicron. And consequently, it has shown a obesity control by reducing the lipid uptake. And so in this study group actually proposed that this can be a promising target for like these obesity related metabolic disease studies. And finally, there is also a organ-specific lymphatic structure that we recently have found out, which is the brain lymphatics. While it was historically believed that both the brain and meninges were devoid of lymphatic vasculature, this meningeal lymphatics has been very recently discovered. So I would like to share the process how this group have actually discovered the lymphatics. So their first purpose was to see how the T cells are like excreted or distributed among the brain vasculatures. So you can see that immune cells like T cells show restricted partitioning near dural sinuses. And they also find that these immune cells were inside the luminal cavity So they imagine that these T cells are inside some kind of vasculature. So after that, they wanted to know what is this characteristics of this vasculature. So it was linearly aligned with the CD31 expressing structure, which is also indicating that it is inside the vessels. And so what kind of vessel was it? They labeled it with a LYVE1, which is a marker indicating the lymphatic endothelial cell. And it was expressed highly. So they could have concluded that these immune cells were aligned linear to the dural sinuses, and these vasculature actually expressed high lymphatic markers, indicating there is a lymphatic in the meningeal space. So this after they found that there is a lymphatic vasculature, meningeal lymphatic, they wanted to know what is the function of this meningeal lymphatics. So they injected a fluorescence dye in this intracerebral ventricularly, and they found out that the CSF was drained through this new novel vessel they have found, which has a characteristics of lymphatics. So this was the first discovery of the meningeal lymphatics. And there are another concept of fluid drainage structure in the brain, which is the glymphatic system. So actually, you should not confuse with the glymphatic and the meningeal lymphatics. The glymphatic is actually a paravascular space, not like a real vascular structure, but it's a paravascular space running through the periarterial and perivenous space. And it has known to have function clearing interstitial fluid in the brain parenchyma. As so, it was named as glymphatic, but it should be distinguished with the meningeal lymphatics. So still, these fluids in the brain parenchyma, so briefly, you can see that the fluids in the brain parenchyma will go through the paravascular space, which is a glymphatic, and it will be collected in the CSF space, which is in the subarachnoid space, and the CSF will be drained through the meningeal lymphatics. And these meningeal lymphatics will then will be collected through the deep cervical lymph nodes. So these were all from the mouse studies, animal studies, and recently it had been also reported that similar structures were also found in the autopsy specimen of human meninges. And using the MRI, it was possible to actually visualize that, like as you can see here, near the dural sinuses, visualize the human meningeal lymphatic network. So recently, many studies regarding the lymphatic and brain lymphatics has been done. So similar to the study shown previously, these lymphatic in the brain, the function also declines with aging. And some other factors are also being studied. One is known that sleeping can enhance the lymphatic clearance and improve the brain homeostasis. So actually, this study have shown that after intraventricular injection of the fluorescence, they calculated the fluorescence intensity counts in the deep cervical lymph node, which is the excretory route of this meningeal lymphatic, and so CSF drainage route. And they have, as you can see, there is a significant difference among the young and aged mouse groups. So you can imagine that as like aging, there is a dysfunction in the lymphatics, and there will be more accumulation of like macromolecules in the CSF space. So because there will be such a relationship between accumulation of such detrimental macromolecules accumulated in the CSF space, there has been studies that this dysfunction will be related to disease conditions, such as like neurodegenerative diseases, such as Parkinson's disease or stroke and subarachnoid hemorrhages. So relationship between the disease severity and lymphatic dysfunction was compared, and they have found out like in the Parkinson's disease model, when ligating the deep lymphatic, the deep cervical lymph node, when they ligated the deep cervical lymph node, it is like it is actually closing, ligating, and it is blocking the excretory route, clearance route of the CSF space. So when doing that, they found out there was a aggravation in the Parkinson's disease. And also it has been shown that the subarachnoid hemorrhage, so erythrocytes from this hemorrhage, also clear through this lymphatics. So when ablating this lymphatics in cervical lymphatics, they found that the SAH-induced mortality actually increased after the ablation of the cervical lymphatics. And similar was also seen when there was a dysfunction in the lymphatic. There was a worsened outcome of the stroke. So also there are reports that decreased clearance of the A beta or tau due to this lymphatic dysfunction can be a causative for Alzheimer's disease. So as you will imagine that accumulation, so this lymphatic dysfunction will accelerate the accumulation of these toxic proteins, like toxic molecules like A beta or tau in the brain. Consequently, this will more induce, or the disease may progress because of such dysfunction. So actually, Professor Dong-Soo Lee and Professor Yuri Choi has shown that there is we have tried a therapeutic approach to modulate such a glymphatic and lymphatic function. And in this study, what we have used was the focused ultrasound, and show that it can actually open up the CSF, and it can actually accelerate the clearance of the CSF through the lymphatic vasculature, and showed an effect in reducing A beta and group-wise improve of the symptoms after this focused ultrasound therapy. So like it looks like a joke at this moment, but no longer there might be a medical device like this. So like accelerating such a lymphatic function, cervical lymphatic function may in the future can improve the clearance of toxic molecules in the CSF space. So we are actually Dr. Asmar from Bangladesh, is now working as his PhD thesis about in the supervision of Professor Dong Lee, is working on to set up a imaging protocol to evaluate this brain lymphatic function in a quantitative and qualitative manner. As you can imagine, previous studies regarding the fluorescence have been used. However, these fluorescence cannot be actually adapted to the human clinical studies because of its inherent limitation. And still, less is known about how to image this CSF drainage function, like how we should inject, or what kind of anesthesia we need to use, or what kind of injection route we should use. This may be clarified from Dr. Asmar's work. So this is some preliminary image that we have shown after the intrathecal injection of the copper HSA, the human serum albumin. We have seen firstly a distribution along the CSF space. And also in the initial time point, you can see the lymphatic, cervical lymphatic, which is the route for this meningeal lymphatic drainage. But this actually, you may image a very similar work is actually ongoing in our nuclear medicine field, which is the cysternography. And we use a technetium DTPA for the cysternography. And we actually injected intrathecally. But you may imagine that we also have not seen any kind of cervical lymph node when using such a technetium DTPA. And so we also have done a study using not this serum albumin, but technetium DTPA injection in the intrathecal space. And we also have found there is no uptake could be visualized in the lymphatics or lymph node, in the deep cervical lymph node. We think that because of its size, and it may be cleared fastly, or it may have alternative clearance routes, not only by the meningeal lymphatic, but also the venous drainage can be a problem. So I think right now, cysternography may not actually be a indicative imaging for the CSF drainage or to evaluate the meningeal lymphatic function. But there should be some more further workups. Also, so these were some disorders like heart or glaucoma or brain disease were shown, but also there is a hype of interest in the relationship between the tumor. So it is well known that these lymphatic vessels serve as an escape route for metastatic cancer cells to regional lymph nodes. But not only as a passive route, but also this lymphatic serve as a function as an active immune surveillance. However, until the era of immunotherapy, it did not have received much attention. But now, because we are actively doing this immunotherapy, there has been a hype of interest to see what is the function of this lymphatic vascular, not only the lymph node, but also these lymphatics in the tumor. Actually, interestingly, this tumor immunity of lymphatics is known to have dual functions. So in the initial period, these lymphatics may have anti-tumor immunity by actually presenting the tumor antigens to the lesional lymph nodes. So as seen in the study, this KCYC model, which impairs the lymphatic function, showed lower rate of tumor antigen presentation to the lymph node. And consequently, there is a lowered cytotoxic activity of CD8 T cells against the tumor. And so these models showed a reduced tumor suppression. However, as the time goes by, there is a paracrine signals from tumor creating a immunosuppressive microenvironment, which affects the lymphatics too. And at this moment, lymphangiogenesis enhancing signals such as VEGF-C can actually inhibit the anti-tumor immunity. So people hypothesize that blocking this VEGF-C will be a good strategy to boost up the immunotherapy. So this study was conducted, and as expected, blocking the VEGFR3 signaling decreased the Treg cell infiltration and delayed the primary tumor growth. However, interestingly, VEGF-C and VEGFR signaling have shown to increase the responsiveness of melanoma to immunotherapy. So it is thought that this VEGF-C may recruit the naive T cell in CCR7 dependent manner, which may actually enhance the immunotherapy efficacy. And additionally, they have shown that these serum VEGF-C may serve as a predictive biomarker for the responsiveness to the immunotherapy. So there are some controversial or dual function of the lymphatics to the tumor immunity by in the initial phase and when the tumor progresses. So still lots to be elucidated in this field. So moving on, same concept also has been discussed after the discovery of meningeal lymphatic. Study have recently shown that there is evidence of activated T cells patrolling in the CNS. So people focused on to find how these adaptive cells go into the brain. And some actually focused on the choroid plexus. And so, however, the next question can be encountered, how are they activated? So after coming into the CSF space and they encounter with toxic molecules, they might be activated. And then how do they communicate with the systemic immunity? And with the discovery of meningeal lymphatic, it gave a clear clue that meningeal lymphatic vessels serve as a route for the drainage of these immune cells in the CNS space, which has come from periphery. And these can moderate this adaptive immunity in the brain. So meningeal lymphatic vessels serve as a route for the drainage of immune cells and macromolecules from the CSF. So in this study, they have shown that ablation of this lymphatic drainage modulates the T cell activation, and it has ameliorate the disease development. So as you can see, lymphatic ablation can reduce the T cell drainage through the meningeal lymphatic, and then the T cell and the antigen presenting cell interaction will be reduced. So the adaptive immunity against this disease will be reduced. And this can be a treatment strategy for such disease like mild, like EAE suppression. multiple sclerosis can be this can be a therapeutic strategy for multiple sclerosis. And also, they have shown that this the VEGF-C can have a protection against glaucoma, and this depends on the draining lymph node and on T cells. So this delivery of the VEGF-C can actually potentiate the checkpoint inhibitor therapy by enhancing T cell priming and recruitment. And also this, in the brain tumors, there has been a report that this meningeal lymphatic mediates the spread of the brain tumor cells to the cervical lymph node. And so VEGF-C, when giving VEGF-C, there will be a enhanced lymphangiogenesis. And consequently, like tumor cells, brain tumor cells will be more presented to the cervical lymph nodes. And it will improve the anti-PD-1 or like CTLA-4 like immunotherapy efficacy. So we have seen that there is many diseases, and many different diseases are actually related with the lymphatic dysfunction. And like aging by aging, this lymphatic can have dysfunction, and this dysfunction may induce a glaucoma or more mortality in the cardiac disease or other neurodegenerative diseases. And also other disease entities are related. And another, not only the drainage function, but also the lymphatics has its function for the immune modulation. So this modulating lymphatic immunity can be a novel target for the immune-based therapy, especially for the immunotherapy of anti-cancer treatment, and also like treatment of autoimmune diseases such as multiple sclerosis. So this was some brief introduction for the first part of lymphatics and related disease. So the next part will be regarding the lymphoscintigraphy in lymphedema, which is more relevant to our interest and our practice in nuclear medicine. And I think we will have a 10-minute break and start with the second session. Thank you very much. And do you have any questions or comments for the first session? Okay, and again, I would like to inform you again about we are actually planning for the next semester. So it will be 2021 fall semester lecture series, and on behalf of and with Professor Dong-Soo Lee, we are actually, we want to know what kind of contents will be helpful for you all our participants. So I think there is a link in the chat. So if you could write down at the last part about what kind of contents you would like to share, we will discuss, and we will choose those contents as our subject for the next semester. Okay, thank you very much. And let's see 10 minutes later.
อ๋อค่ะยินดีที่ตามหาไม่เจออ๋อค่ะเพราะว่าเป็นชื่อพอดีที่บ้านเป็นทนายความสามีเป็นทนายเคยอยู่กรมธรรม์ดีและพี่เคยเรียนสีหน้าที่บอกอ๋อชักได้อยู่ตรงนี้เอง
Okay, I think it's time. So if everyone can hear me, I will start the next session about the lymphoscintigraphy in lymphedema. So can you hear me?
Yes, Professor. Perfect.
Thank you very much. Okay, so the next part will be the lymphedema, which is more familiar to us. And this, so when there is a blockage in the lymphatic passage, this fluid in the interstitial space pile up. And as a result, proteins and cellular debris may also accumulate in this interstitial space. And this accumulation of cellular debris and macromolecular or materials may induce an inflammatory reaction and cellular damage. And this will actually consequently lead to the fibrosis. And after this fibrosis, the interstitial space and lymphatic vasculature, actually it gets irreversive. And this is some pathophysiology, some process of the lymphedema. So there is, as seen previously, there are some diseases, some gene-related congenital disease, which were like VEGF3, VEGFR3 or FOX2 related congenital disease. And these congenital disease can be classified as a primary lymphedema. And also there are other secondary lymphedema, which is the prior causative are well known, including filariasis, the prostate infection, which is quite globally have a high incidence. And also because of therapeutic surgeries like cancer, the lymphedema due to cancer malignancy, such as breast cancer or gynecological cancers, which need a axillary or inguinal pelvic lymph node dissections. And also like chemotherapy or especially radiation therapy can aggravate or accelerate the induction of this lymphedema. In the Department of Nuclear Medicine, we conduct a lymphoscintigraphy for the evaluation of lymphedema for the lymphatic system imaging, and radiopharmaceuticals with a relatively large particle size, which is in between 15 to 100 nanometers, are adequate for evaluating the shape and the function of lymphatic vessels and lymph nodes. Because these sized molecules can sufficiently enter the lymphatic capillary, but they cannot enter the blood capillary. So they are drained only through the lymphatic system. By using it, this lymphoscintigraphy is right now a gold standard imaging modality for lymphedema with high sensitivity, up to 96 to 100%. So what are the function? What are the usage? These are some which indication that lymphoscintigraphy can be used. First is the differential diagnosis of edema. And the second might be to see the treatment status of the lymphatic treatment, functional improvement after treatment. And that also not only the differential diagnosis, but actually it can be used as a to visualize the functional status and severity of lymphedema in a qualitative and quantitative manner. And recently, there has also been studies that have shown that lymphoscintigraphy finding can be a predictive marker, or also it could guide the therapeutic choice for the lymphedema. Okay, there are many causes for edema, which some differential diagnosis will be venous edema, mixed edema, lipedema, or also the lymphedema. So I will show you some case. So this was 22-year-old female patient, which had a chief complaint of leg swelling 3 years ago. And it started swelling from left foot to thigh level. And she had a pitting edema and stammer sign. So for the differential diagnosis, firstly, she had undergone a study and there was no evidence of deep vein thrombosis. So it like venous edema can be excluded. And nextly, she underwent the lymphoscintigraphy for the diagnosis of lymphedema. And as you can see from the initial point of image, there is some lymphatic drainage in the first the right side, and there is some visualization of the inguinal lymph node. However, the left side there is no lymphatic flow visualized, which indicates a severely delayed lymphatic flow. And after 1 hour, and there was a stress protocol in between that. And after 1 hour, you can see that at the right side, there is some, along the lymphatic drainage, there is also some dermal backflows. However, still, the inguinal lymph nodes are visualized. And the left side, also now there is some visualization of superficial lymphatic drainage through the inguinal lymph node. However, there is a severe dermal backflow in the lower leg area. So this patient is, regarding the image finding, this patient has is consistent with a lymphatic dysfunction in both legs. So and also this patient had no other causative for this development of lymphedema. She was actually diagnosed as primary lymphedema and had a treatment. And next is samely, a 45-year-old female patient who had a leg swelling 2 years ago. And also it had a swelling from both foot to thigh level. And she had a pitting edema and stammer sign. However, when you see the lymphoscintigraphy, you can see that there was no actual evidence of the lymphatic dysfunction or obstruction. So this patient consequently was diagnosed as lymphedema and had a treatment regarding to it. So for the differential diagnosis of the edema, and to actually diagnose the lymphedema, this lymphoscintigraphy has very high sensitivity and specificity. And as well as this differential diagnosis, the functional severity of lymphedema can be evaluated based on the images. And these are some studies that have summarized the grading system from referring to the lymphoscintigraphy findings, such as some important points of lymphoscintigraphy findings are whether the visualization of the superficial lymph node and dermal backflow, the extent, or the radiotracer extent, or whether there is a collateral flow, are some important image findings that they have used for the gradings. So I would like to share some studies So this is first study is a paper published in Lymphology 2005 by Lee and Bergen group. And lymphoscintigraphy was evaluated and classified into 4 stages according to the lymph node visualization, thermal backflow, and the collateral flow. So firstly, the grade 1 and 2 can be divided by whether there is a lymph node in the inguinal side or not, or like axillary lymph node visualization. And after, like detailed groups, like 1 and 2 and 3 and 4 are divided according to the visualization of the thermal backflow and whether there is a collateral flow. So like if there is no lymph node visualization and some thermal backflow, it can be graded as 3. However, if there is no any radiotracer extending to the leg, it can be classified as grade 4. So using it, after dividing this lymphoscintigraphy finding and grading, and this grade also showed a high correlation with the clinical stage, as you can see. And in addition, actually, more interestingly in this study, so like 26 out of 34 patients, so it's about 76 patients, so 34 patients had a so this 34 patients had a disease progression according to the initial clinical stage. And so like these 34 patients have higher final clinical staging.
Ông cứ giữ đi rồi anh nghe cái gì đó. Giữ anh nghe luôn đi.
Could you turn off the mic? Yeah, thank you very much. And from the 34 patients, have a questions or comments? Okay. So from this, about 76% of patients. Oh, sorry. Okay, so about 76% of patients had a higher lymphoscintigraphy grade compared to the initial clinical stage. So it can be seen that lymphoscintigraphy finding will reflect the disease progression and prognosis, as well as the severity at the time of the imaging. The following study conducted by Peking Group is a large-scale study that analyzed more than 4,300 subjects. In this study, also, like this first 0 to 2 stage and 3 are classified based on whether the lymph nodes are visualized. And from 0 to stage 2, it is also classified based on the dermal backflow and the collateral flow. So, sorry. And in this study also, after the grading, this lymphoscintigraphy grade showed a high correlation with the clinical stage, classified according to the criteria. The clinical stage was classified according to these criteria. And actually, in addition, the study reported the treatment effect of CDP, the complex decongestive therapy, and at grade 0. And so the lymphoscintigraphy finding and clinical stage was merged, and they graded as 0, like this early stage patient, which has grade 0 and 1, had better response to this complex decongestive therapy. And so compared to the more higher grade patient. So it can be a thing that this lymphoscintigraphy finding can also could be used for the prediction of the therapeutic effect. And the next study is a study from Cheng's group published in Annals of Surgery in 2018. And they adapted a 7-step grading system. And so firstly, if the partial and total was divided regarding whether the lymph node was visualized, and detailed classification was based on the extent of the dermal backflow or the collateral flows and collateral flows. And after this staging system, they identified a correlation between clinical symptoms such as cellulitis and like circumference difference and CT volume differences. So the grading system of the aforementioned studies can be summarized as shown in this table. And as you have seen, the most widely used classification is based on whether there is a lymph node visualization. And after that, detailed classification is performed according to the dermal backflow or collateral flows. And these grading system seems to show difference depending on what kind of radiopharmaceuticals they have used in their study, or what kind of therapeutic they have applied to the target group, or what kind of clinical stage they have used to compare with this lymphoscintigraphy finding. And like, for instance, for the treatment application, as in this packing group, you can see that they have more detailed classification for the early stage patient who have a lymph node visualization. So, and in this packing group, the therapeutic strategy they applied to the patient were the CDT, the complex decongestive therapy, so they have more focused on the earlier stage of the patient. However, like Maegawa and Cheng's research, the subjects have underwent a lymphovenous anastomosis, which will be discussed later on, and which is actually applied to more later stage patients. So they seem to have focused on more detailed classification of these later stage patients. Okay, and in addition to the findings like this qualitative image-based severity evaluation, our lymphoscintigraphy allows a quantitative evaluation, and various quantitative evaluation factors are used in research. And first of all, as mentioned previously, the method, the important factor in the visual analysis was whether there was a lymph node visualization or not. So there has been a method for evaluating the uptake of the lymph node. And as you can see, one can use as the contralateral side will be normal. So they can use a quantitative asymmetry index comparing to the normal side. Or you can actually get a lymph node to background ratio like this. And however, the evaluation of this lymph node uptake can be limited in late stage patients who don't have any visible lymph nodes, or in patients with very poorly, like whether the normal part, if the normal part is not, if there is a dysfunction in the normal part, it is also hard to evaluate. So there are alternatives markers that are used, like we can use a liver uptake at a certain time point. And it utilizes the fact that when these radiotracers enter the systemic circulation, they are, because of their size, they are taken up in the liver. So you can actually estimate the radiotracer in which have entered the systemic circulation by checking the uptake in the liver. And also another way is to draw an ROI in the injection site and to get a time activity curve of the injection site and get the clearance of this radiotracer. So there has been a study that have shown that these quantitative indexes have relationship with the symptoms or the clinical, and this quantitative markers have its clinical significance. So this study actually included patients who without a significant dermal backflow, and they calculated that the quantitative asymmetry index of the like forearm and upper arm and also the total arm. And they have seen that these quantitative asymmetric index has a relation with the symptom severity. So as you can see that the first patient had a forearm index of the 1.14, and also the maximum circumference difference was minimal. However, the patient which had a higher asymmetry index had a higher maximum circumference difference. However, currently, there are some concerns about applying the lymphoscintigraphy. So first of all, there are various radio tracers used for lymphoscintigraphy. And as you can see, they have various sizes, and due to it, it has different speed of movement within the lymphatic system. So to actually establish a protocol, these kind of speed of the radiopharmaceutical will be considered. And also the problem is that because different sites use different radiopharmaceuticals, like interchange, the comparative studies are quite limited. And also the type of injection differs from site, and it also differs based on what kind of radiopharmaceutical they use. And the radiopharmaceuticals are usually injected into the subcutaneous or intradermal to check for the superficial lymphatic flow. And it is known that intradermal injection shows relatively fast lymphatic clearance compared to the subcu injection. And it is known that images can be obtained at slightly faster time point. And also lymphatic vessels can be seen at a little more clear view. However, most of radiopharmaceutical, like especially the colloid-based radiopharmaceuticals, are weakly acidic. So intradermal injection can cause a stronger pain than the subcu injection. So like in the usual study protocols, like colloidal-based these radiotracers are usually injected through the subcutaneous injection. And since the albumin-based the tracers may show a neutral pH, so it is more injected through intradermally. And also, intramuscular injection is a route to confirm deep lymphatics. And recent studies actually have reported that detecting this deep lymphatic as well as superficial lymphatic can increase the sensitivity of the test. And next concern is that there are various ways to give a stress. To actually giving a stress like in between the initial and the delayed time point are readily used in our clinical practices. And it can actually enhance the sensitivity, or it can enhance the utility of quantification. However, because of the various type of the stress protocol, it can reduce the reproducibility of the study. And since this like massage or exercise is based on the individual, is performed by the individual, so it is actually inherently subjective. So actually, currently in Seoul National University Hospital, we are conducting a research on the development of a stress protocol using pneumatic pump. So rather than entrusting the exercise to individual patients, the pneumatic pump can be used to consistently apply stress. And furthermore, we expect that the effect of pump treatment can be predicted in the future. So this is some brief, I would like to briefly share the result of preliminary analysis on patients who have performed the examination to date. And so after the application of the pump, so as expected, it can actually enhance the flow or the movement of the radio tracer, and we expect that it could enhance the clearance. And so after the application of pump, lymph node was seen in more than 60% of patients in the delayed image, and more than 88% of patients showed an increase in flow extent. And as a result for the comparative evaluation in subgroup of patients who had a previous scan, we can see that when just using the conventional stress protocol for the upper extremity, just a hand grip, and the lower extremity, just a walking, this conventional stress protocol, compared to that, we can see that there are more patients who have visualization of the lymph node. And also there are more patients who have a more wider range of flow radio tracer extent after the this pneumatic pump. So we expect that the drainage of radio tracer can be promoted according to the application of pump. And because we are giving a same stress amount, this can be more objective compared to the patient-based massage or exercise. So in summary, lymphoscintigraphy can show changes in lymphatic system function according to exercise. So it can be used for the differential diagnosis of the patient. And lymphoscintigraphy can visualize the functional status and severity of the lymphedema in a qualitative and quantitative manner. However, because like different sites are using different protocols, so comparison across the studies are limited, and these different protocols should always be in mind and should be considered when you evaluate the lymphoscintigraphy. And following, I would like to explain how lymphoscintigraphy can be used for the evaluation of the treatment response. And following is the current treatment options for the lymphedema. However, like all these treatments, the therapeutic effects are somewhat limited for now. But the non-surgical, firstly, non-surgical treatment options are complex decongestive therapy, and there is a compression therapy or manual lymph drainage, or also stellate ganglion block, which is blocking the sympathetic tone, can have a therapeutic effect. And for the surgical treatment, what we widely use is a liposuction, and lymphovenous anastomosis can be used, and also lymph node transfer can be used. So this study actually seek the findings after the complex physical therapy, the CDT therapy, and they have suggested a improved lymphatic function after this therapy, and decrease in dermal backflow and increase in radioisotope uptake by lymph node, and also increase in radioisotope uptake in lymph node were seen after the treatment. However, there was no significant correlation between the lymphoscintigraphy improvement and amount of the volume reduction. So there is some discordance between the lymphoscintigraphy change and symptomatic change or the volume clinical markers change. And next study, patients were evaluated who underwent the lymphatic venous anastomosis, and they have seen that the patient with both dermal backflow and they have shown that this lymphoscintigraphy with SPECT-CT can provide both functional and morphological information, and the therapeutic efficacy of this surgery could be estimated quantitatively. So following that, you can see the cases after the lymphatic venous anastomosis, that this is from the previous surgery, pre-surgery lymphoscintigraphy. You can see a dermal backflow in the thigh area. However, after the surgery, you can see a significantly reduced extent of the dermal backflow in the right side thigh area. And also the volume and clinical factors were reduced. Next case, you can see that there is a dermal backflow. Before surgery, there is a dermal backflow localized in the lower leg, and some faintly visualized inguinal lymph node can be seen. However, after the surgery, you can see that the dermal backflow, although the intensity has been somewhat decreased, but the radiotracer extent is very limited to the lower leg area, and no inguinal lymph nodes are visualized. And also, which was relatively normal at pre-operation, this left side got worsened after the surgery, more significantly increased dermal backflow was seen. So there was a worsening in the lymphoscintigraphy finding, and as you can also see that there was also increase in the volumetric parameters and clinical symptoms. So as from the cases, there are tendency of correlation between clinical symptoms and lymphoscintigraphy finding improvement. However, still, there are also significant portion of patients have discordancy, which may need, actually these may need further follow to see the clinical significance of surge discordancy. And in addition, in this study, the lymphoscintigraphy findings were evaluated comparatively with the ISR stage. And results indicated that as the higher ISR stage, there is a higher chance of worsening from the lymphoscintigraphy finding, and which indicates that these, as the ISR stage gets higher, there will be a more chance of non-functioning lymphatic vessels, like more fibrotic lymphatic vessels, and which will consequently have less effect from the lymphatico-venous anastomosis surgery. So this group also insisted that the lymphatico-venous anastomosis should be conducted more in the earlier period. So as a summary, lymphoscintigraphy can show functional improvement of lymphatic after treatment. However, there are some discordancy, as you have seen, between the symptomatic improvement and the lymphoscintigraphy finding. So further correlation with a long-term prognosis is needed to see the significance of such discordancy. Next part, I would like to introduce that from the recent studies that lymphoscintigraphy findings can be used for the prediction of the therapeutic response or the prognosis. So firstly, I would like to introduce some studies regarding the complex decongestive therapy. And this CDT is a gold standard for treating lymphedema and consists of a two-phase, decongestion phase and maintenance phase. And it consists of 4 elements like manual lymphatic drainage, compression therapy, skincare, and exercise. And it aims to reduce your swelling and improve the condition of your skin and increase your mobility. However, this CDT is likely a care, but not a cure. Still, it is the gold standard treatment right now for the lymphedema. And this study aimed to find a lymphoscintigraphy finding associated with the CDT treatment effect in patients with upper limb lymphedema, and reported that when axillary lymph nodes were visualized, it is a marker indicating that this patient will be highly effective in CDT treatment. So as you can see, like in the first patient, which have a dermal backflow and axillary lymph node, will be a good candidate for the CDT therapy. So like compared to the non-visualized group, these patients showed a better response to the CDT therapy. And also in the quantitative manner, there was a similar report. And this study showed a correlation between the level of lymph node uptake and the level of volume reduction was positively correlated. And they also reported that patients with higher lymph node uptake or lymph node visualization had a higher therapeutic effect after the CDT. And the next therapeutic option is the stellate ganglion block. And they're still like by blocking the sympathetic tone, it is known that it will dilate the lymphatics or dilate, and it may reduce by the dilatation of venous or lymphatic space. It will reduce the interstitial space pressure, or so it can actually improve the drainage of the lymphatics. But still, the underlying mechanism of such stellate ganglion block is not really described. But still, the studies have shown a therapeutic effect if the stellate ganglion block was performed bi-weekly. So we also have conducted a study comparing the treatment effect of CDT and SGB, and whether like lymphoscintigraphy finding were indicative of what kind of therapy will be more beneficial. So the main findings that we classified were the lymphatic. First was the lymphatic flow pattern. So whether all the trunk like were visualized, or whether the flow or radiotracer extent was restricted to the forearm. Or next parameter was whether the lymph node was visualized or not. And the last parameter was about the dermal backflow extent. Actually, now we think that this dermal backflow extent and the lymphatic flow pattern has somewhat similarity. So like small extent group will be more inside this forearm restricted pattern groups. So after defining the characteristics of lymphoscintigraphies, we evaluated each in two groups of patients. And as you can see that there is no significant difference in the findings of CDT and SGB group. So I think these two groups are well separated and no significant difference in the lymphoscintigraphy finding. And also you can see that this both the SGB and CDT therapy had a therapeutic effect compared to the baseline. And when we see what kind of image findings were indicative of the therapeutic effect of each therapeutic aid strategy, we have found that like in the forearm restricted pattern group, compared to the CDT, SGB was more effective to reduce the circumference of the arm. And also the lymph node non-lymph node visualization group or small extent of dermal backflow group had a higher therapeutic effect after the stellate ganglion block. So we may actually, by the lymphoscintigraphy finding, we may guide what kind of therapeutic strategy this patient will go on. And the last therapeutic strategy is the lymphatic venous anastomosis. And it is actually connecting this lymphatic vessel, somewhat leftover functioning lymphatic to the nearby vein to drain the lymphatic directly to the nearby veins. So there are many studies that have proven that these lymphatic venous anastomosis may improve. And still there are many studies working on for their efficacy. And also, so studies have focused on what kind of image findings are indicative of, or what could be the inclusion criteria for this lymphatic venous anastomosis. And this group actually divided the patient into 5 scale, and this is the Meningeal group, which I have previously shown in the summary table. And this group actually divided patient firstly by the lymph node visualization by 1, 2, and 3 to 5. And by the dermal backflow extent and collateral, they did more, subgrouped it, 3 to 5 patients. And after grading, they have seen that the finding they have focused on was how many sites the lymphatic venous anastomosis was made, was their main finding. And they have indicated that type 3 had the most highest number of lymphaticovenocytes found in the surgery environment compared to other like type 2 or 4 to 5. So they have reported this kind of type 3 patient will have relatively relative functioning lymphatic left, and also dilated lymphatic, which is more relatively easier to find in the surgical field to be connected to the nearby veins. And compared to that, like type 4 or 5 will have relatively non-functioning lymphatic vessels. So although you can find it easily, although connecting to the nearby vein, it will not function. And compared to that, type 2 may have relatively well-functioning lymphatics. However, because of it's not accompanied by the dilatation, it might be, they indicated that it might have been hard to find such a lymphatic vessel in the surgical field. And further, they have compared whether these findings were relative to the surgical outcome of volume reduction. However, there was no significant difference according to each group of the volume reduction. Still, another study have found what are the lymphoscintigraphy findings that will show a beneficial clinical result after the surgery. So they have found that comparing the group who had improvement after the anastomosis compared to the who have not had an improvement, there was a significant number of patients had a dilated lymphatic vessels in the lymphoscintigraphy finding, and also dermal backflow. So like in this is the pre-scan before the surgery. And as you can see, the patient have like dermal backflow and some dilated lymphatic vessels. And after the surgery, this patient showed very well, no significantly decreased extent of dermal backflow. So I would like to share some case. So first is 70-year female patient who had right leg swelling and pain. And the swelling was from right foot to thigh level and had a pitting edema, stammer sign, and heating sense also. The patient had a history of endometrial cancer, which she had accompanied by the pelvic lymph node dissection. So from the lymphoscintigraphy, you can see that the patient, at the initial, there is a superficial lymphatic flow visualized and some decreased lymphatic lymph node in the inguinal side. And at the delayed pace, you can see a dermal backflow in the thigh to knee level areas, and also still decreased inguinal lymph node was visualized. So actually, this patient had was consistent with lymphatic dysfunction or obstruction in the right side. And so the SGB and CDT therapy was applied to this patient. And as you can see, still the patient, the CDT therapy actually, yeah, so, oh, sorry. So there is some still a wax and wane of some of difference, but and there was a therapeutic effect. I think the ear is wrongly indicated, but after the therapy, there was an improvement in after the CDT therapy. However, after the therapy, this difference still went progressed after the therapy. And the next case is oh, sorry, I think I have wrongly indicated the case. Okay, so I will explain again. Sorry, so this is a lymphoscintigraphy, which was done at 2010. And after this, the patient had a stellate ganglion block and CDT therapy. And however, there was a aggravation after the therapy. So you can see, like after this is lymphoscintigraphy, which was done at 2017. And compared to the previous lymphoscintigraphy at 2010, there is a more increased extent of dermal backflow in the right side of the right leg area. And so this patient was referred to the plastic surgery for the lymphatico-venous anastomosis. And as you can see, we do before pre-surgery, we do some SPECT CT analysis to seek whether there is a functioning lymphatic vessels. And as you can see, in the right side, there are still some functioning lymphatic vessels in the lower, the ankle level areas. So this patient have underwent lymphatico-venous anastomosis, and they found a anastomosis site in the ankle level, which is similar to the level that were indicated in the lymphoscintigraphy. And after the end-to-side anastomosis, after the surgery here, they have found a improvement in the sum of difference in the circumference of the lower leg. And the next case is 58-year-old female patient who had lower extremity lymphedema after the gynecological cancer treatment. And this is a pre-LVA lymphoscintigraphy. And in the 5-minute image, you can see a visualized axillary lymph node, which is very faintly decreased visualization. And also collateral lymphatic flows are visualized. And at 30-minute and 60-minute, you can see a dermal backflow in the thigh level and visualized axillary lymph nodes still relatively decreased, which is consistent with the lymphatic obstruction. But as you can see, there are some functioning lymphatics in the lower leg area, and also it is appeared to the mid, like knee levels. So the patient underwent lymphovenous anastomosis surgery, and it was done at this knee level and ankle level, which also lymphoscintigraphy have shown there is a functioning lymphatic vessels. And they found a site lymph to be connected to the vein, side vein. So 2 sites were done as a end-to-end anastomosis. And after that, as you can see, the lymphoscintigraphy also was taken. And so this is the pre-scan before the surgery, and this is the post-scan. And you can see compared to the pre, there is a decreased extent of dermal backflow in the thigh level and more, and also the important finding in the 60-minute you can see is that compared to the pre-surgical lymphoscintigraphy, there is a higher uptake in the liver and also higher uptake in the blood pool area, indicating that because of the lymphatic venous anastomosis, there are more chance of radiotracers directly going into the systemic circulation and drain from the injection site. And when they enter the systemic circulation, it will end up in the liver. So after the surgery, it have shown because that there is higher radiotracer accumulation in the liver and also the blood pool, indicating that this lymphatic venous anastomosis is working well. So likely there was a improvement in the circumference after postoperative 6 months evaluation they have seen, and especially along the thigh area and also in the knee areas. But still, as we have seen, there are various uses of lymphoscintigraphy, but there is a clear limitation about the lymphoscintigraphy, which is it is very low spatial resolution. So like, as you can see, these when the lymphedema progresses, it progresses like stage 0 to 5, and it in the fluorescence, like lymphography, you can see like linear or splash or stardust pattern or diffuse dermal backflow at the later stage. However, these all actually cannot be distinguished in the lymphoscintigraphy. So like in the initial image, you can see some functioning lymphatics in this patient, and which can be a some lymphatic vessel which can be connected to the nearby vein. However, like in most of patients, what we look is such a end up of just a dermal backflow we cannot actually localize such a functioning lymphatic vessels. So in order to overcome these limitations, researchers have introduced some SPECT-CT work, and they have shown that when applying this SPECT-CT, we can have a additional information regarding a extent of lymphatic transport disorder or visualization of lymph vessels or like anatomic allocations. And next, also another problem or limit right now lymphoscintigraphy protocol is that we are actually injecting the radiotracer only in the distal side, like in the interdigital web. So what we see is if the lymphatic flow is delayed in the lower leg area, actually the upper part is not actually evaluated. So there has been some alternative approach by using the ICG lymphography by multi-site injection ICG lymphography, and they indicated that using this multi-site injection, they can find more sites for the anastomosis before surgery. And there are also studies to use the MRI lymphangiography and MRL. And so in this study show that MRL and lymphoscintigraphy show a clear concordance. And actually the MR lymphangiography had a higher, because of its better resolution, it can have better depiction of lymph vessels. So in shortly, lymphoscintigraphy can predict the effectiveness of lymphedema treatment and can help in setting treatment. However, there is a clear limitation of low resolution. So if evaluated in parallel with other lymphography methods like MR lymphangiography or the ICG, it is expected to generate a synergistic effect. So this is some brief about the treatment options and the grading system, relationship with the grading system. And normally until now, the studies indicate that these CDT treatments are more effective in the earlier stage compared, and it may not work well in the patient with a higher stage in the lymphoscintigraphy finding. And compared to that, stellate ganglion block might be more effective in the later stage patient. And the lymphatic venous anastomosis, the studies now have shown that it is beneficial. It can be beneficial in the patient who have like dilated vessels or dermal backflows. But however, from the cases we have reviewed in our cases, we think that there is also some beneficiary patient in the earlier group. And also it is indicated that before the lymphatic vessels get dysfunction, this LVA surgery should be done. Okay, so in summary, lymphoscintigraphy can be used for the differential diagnosis of edema and can evaluate the function and severity of lymphatic system qualitatively and quantitatively. And lymphoscintigraphy can also image changes in lymphatic system function according to, and it is expected that it can be used to predict the treatment effect of lymphedema based on the imaging findings and quantitative data, and further select a treatment strategy. And also from the first part, we have seen that this lymphatic dysfunction may induce various kind of diseases, such as like heart disease or neurodegenerative disease or glaucoma or other. It can be also related to the obesity. Okay, thank you very much. And I will finish the presentation. Do you have any questions or comments?
I'm sorry, Professor, I have a question.
Oh, so it's in the chat. Okay, so there has been a question about which one is the best lymphoscintigraphy procedure when using a colloid tracer, since there is no international guideline for the lymphoscintigraphy. So I think it might be different according to the purpose, but just for the differential diagnosis of lymphedema, actually like the initial time point and giving a stress and then doing the 1 hour delayed scan might be enough. But you need to, I think the important thing is what might be the purpose of the study. So if you want to evaluate like response of the CDT, actually it might be good to, it might be interesting to apply a stress protocol like using the pneumatic pump, since the CDT therapy actually includes the lymphatic, this pneumatic pump. So it can actually show the therapeutic effect directly. Or if you are considering to find out like some functioning lymphatics for the LVA surgery, then there should be an earlier time point imaging, because at the delayed time point, what you end up is only seeing a dermal backflow overall in the like all over the extremity. So like more earlier time point images, like five minutes for initial time point, and 10-minute or 20-minute might be, so earlier time points should be acquired to actually see some functioning lymphatic vessels and also collateral vessels. So I think it can be differed according to the purpose of the study. And I would like to ask, so I would show you again about the quantitative parameters that can be used. Okay, so there are some quantitative parameters right now used, like you can actually draw an ROI in the like axillary areas and get the asymmetric index compare, and it can be applied when there is a normal side. Like for the breast cancer patient, they only do the surgery at the like unilateral side, so the counterpart will be we assume it will be normal. But still, as I explained, there is a patient-based variance, like patient may have different dysfunction in the normal side also. So these kind of patient factors should be also considered, but still you can take easily like this asymmetric index. And like if there is like patient, for instance, like both side dysfunction, you can use also like lymph node to background ratio to actually acquire the uptake in the lymph node. Or like as you have seen for the lymphatic venous anastomosis studies, you can acquire the uptake in the liver to background or liver to blood ratio. And this actually can be indicated of the amount of radiotracer which have been entered through the systemic circulation. And to that, also another way to actually see the clearance of you can see the clearance of the radiotracer in the injection site. So you draw an ROI in the injection site, and then you can get a time activity curve from that injection site. This like you can not like this all these time points. You can also get like 5 minutes and 1 hour, and like how many percentage has been cleared can be actually quantified. So the purpose actually is that it might be so like so the next question was, so what is the purpose for the quantification? So actually it is very, I think, good question that we can easily read, and we can actually grade the lymphoscintigraphy finding according to the image-based analysis. However, like for the treatment response or to evaluate the therapeutic response, in my experience, like after the treatment, by the finding or by the grading of the lymphoscintigraphy, actually there is not that much change. So to actually more objectively show the result of the treatment response, it might be better to use such a quantitative markers or these indexes. So that's some purpose. But I also agree that like this quantification is not necessary for a usual clinical practice for differential diagnosis or just for the prediction of the therapeutic effect. It is actually not necessary. Okay, and the next question was that when applying a nanocolloid and with intradermal injection, what will happen is it affect the image? Okay, so usually when we use a colloid agents, as previously mentioned, we do a subcutaneous injection. And actually, it is due to some, firstly, it is weakly acidic, so it can actually evoke pain to the patient more than so intradermal injection will evoke more pain compared to the subcutaneous injection. But still, the image, and also the image can be different because when you inject it in intradermally, actually it is known that it will be cleared slightly more faster than the subcutaneous injection. So some articles and reports suggest that intradermal injection is better if the pain is not a problem. It might be a better protocol for more faster imaging and also more like sensitive imaging. But still, in our institute, we used just a we use colloid-based radio tracer, and we use subcutaneous injection right now. Okay, would there be another or some other questions or comments?
Good afternoon, Professor.
Good afternoon.
Yeah. Thank you for the interesting lecture, Professor. I am Rian from Hasan Sadikin General Hospital in Bandung.
Hello.
Yeah, hello. I would like to ask about brain lymphatic imaging. What's different between cysternography and brain lymphatic imaging? Is it same or different? Thank you,
Yeah.
Professor.
Okay. Actually, the injection route is same, and actually it is same. So, yeah, and and actually there is no gold standard imaging protocol right now for such a meningeal lymphatic imaging. And like whether the imaging tool to evaluate the CSF drainage is not well known right now. But what's the difference that we think is that when we use the DTP, technetium DTPA, and which is the widely used in the cysternography, it actually does not accumulate, or we cannot see the cervical lymph node in the patient. So we have done like we do like 24-hour imaging and 4-hour, 6-hour, and 24-hour imaging after the cysternography, but we cannot see the cervical lymph node in those patients. And the reason I think is because of the size, and the clearance route might be different. And I think DTPA might be cleared through the sinusoidal, or it can be directly cleared through the systemic circulation. So which means that it may not reflect the clearance of the CSF through the meningeal lymphatic, and it may not reflect the clearance of the macromolecular or toxic materials clearance in the CSF space. So what we are testing is to use a more macromolecule, such as human serum albumin, may reflect such a clearance route of the CSF. So I think that's the difference. I think, would that be the answer for you? Okay. Yeah.
Thank you, Professor.
Okay.
Yeah.
And there has been a question, is there any normal range value for clearance or lymph node background ratio and liver to blood ratio? Sorry, there is no reference ratio, because the most problem I have introduced is that because all the studies, all the institutes use different radio tracers and different imaging protocols and different stress protocols and even different injection sites. So you need to develop your own reference range is, I think, my opinion. So you need to develop your own institute's normal range of the clearance or like uptake in the liver by like, if for the clearance, for instance, because there may be many patients who have spared a normal side, then you can use that as a to make a data of the normal range of the radio tracer clearance. And for just for some example, we use antimony sulfur colloid in Seoul National University right now, and the clearance we think was near like 10% at 1 hour period at the injection site. But it is I am sorry but there is no, as I know there, there is no actual like normal range for now, but you need to make it by your own. And there was question about ICG lymphography, and we actually in the nuclear medicine department, we do not do the ICG lymphography, but our plastic surgeons preferred before surgery, they always do the lymphography before the surgery to actually find some like functioning lymphatic vessels and where to do the lymphatico-venous anastomosis, but actually we do not do. So I think the difference between the lymphography and our lymphoscintigraphy is that we can give some gross picture of the lymphatic function and the shape. However, for the detailed lymphatic, to more focused on the lymphatic vessel for the surgery, I think combination with lymphography or ICG or the MRI lymphangiogeography will help. But one thing that lymphoscintigraphy may have more power compared to the lymphography is that there are recent studies that are focusing on to do the deep lymphatics using like intramuscular injection. So lymphography may not give, because it is a fluorescence, it cannot give you an image of the deep lymphatics. So actually this lymphoscintigraphy, we can have information about how the deep lymphatics are changed according to the disease progression. And some reports are saying it may be more, it may give additional information it may give additional information. Okay, and would there be some other questions or comments? Okay, if there aren't, before closing, I am sorry, but I would like to again inform everyone to participate in the link in the chat and I would like everyone to actually give us some comments about what kind of subject you want to hear from the next semester. So we are preparing for the 2021 second semester lecture series, and we are figuring out what kind of contents and topics will be beneficial for everyone, every participant. So if you give us your ideas, we will we can use that for our schedule planning for the next semester.
Okay, thank you very much. And this will be the end of our my lecture. Thank you.